Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Dr. Michael Singer. Welcome back to Retina Synthesis, Michael.
Carmen, it's always great to be here. I really enjoy your podcast. And again, I love the opportunity to share new and interesting things because many times I'm on the other end listening to them. So I'm thrilled to be part of the program.
We've talked about cooling anesthesia for intravitreal injections previously on this podcast, but this field has continued to evolve. Can you tell us what this is all about?
Sure. So interesting, we think about this as from an idea to an approval, right? So one of the things we know is we have different ways to numb the eye, right? We can numb the eye using drops, we can use gel, we can use subconjunctival anesthesia, and there's obviously both a time element to this and a process element and a patient comfort element. And again, the current therapies have pluses and minuses, but some people still obviously get traumatized by the process of going through the anesthetic process, the getting involved with the antiseptic process as well. So all these things become really complicated, and we always want to, and over time, if you look at the corneas of these people who have had drops or gels or subconjunctival anesthesia, you can see some corneal toxicity as well. So that was the genesis of potentially looking at the concept of using cooling. Cooling's been around in other fields for a long time, and there have been other studies that show in skin procedures and other procedures, especially like if you look at people who get Botox, they use cooling. They put ice packs on it or lidocaine gel. So again, there's been some use of cooling in other fields that are related to intravitreal injections about being around the eye, but this is the first time really trying to use cooling in the eye. And the device is basically a cool gun. And what it does, it rapidly anesthetizes the eye through precise cooling technology. It works in less than 45 seconds. And the hope is that the patient's going to have a better comfort experience and less toxicity of the cornea from the different ointments and gels that we use. So what they did was they did some rabbit studies to make sure they could find the right amount of cooling over time, and they did 40 treatments, and they showed that essentially there was good enough cooling and there wasn't tissue damage, because those are the things we were worried about. If you freeze and thaw, you might have tissue damage. It's not like you in cryo. We think of cryo as being something that's um, very permanent and very damaging. This is much shorter time, not as deep of cooling, but enough to control the process. And they ran a bunch of different cooling studies, and what they wanted to, they did questionnaires and they did different types of cooling amounts, and they realized that 15 degrees centigrade at 10 seconds seemed to be the right amount of time with terms of controlling enough of the anesthetic component without causing any significant damage. So what they did was they did 15 degrees Celsius at 10 seconds, like I said. They ran these studies and they showed value. So they ran something called the Cool 3 study. And what the Cool 3 study essentially did was compare it to traditional medicine. The interesting thing was, patients did feel definitely thought there was value to the process. The FDA did give it approval, but they did say it has to be people who have allergies to lidocaine. What's interesting thing to do in the Cool 3 study, the average pain score was about 2.1 versus about 1.5 with the lidocaine, but it was non-inferior, and it basically was enough to get it approved because it didn't cause a lot of damage. We have used the cool technology in our clinic, and for the right type of patients, it has done really well. The way you do it essentially is you'd put a lid speculum in the eye, as you typically would do for an intravitreal injection. You give a betadine drop, in general, where you're eventually going to use the medication. I mean, the freezing device, you're going to put the cooling device, actually has its measurement built into it, so you know exactly where 4 millimeters from the limbus is. And by you do a freezing, the gun actually goes, and then it tells you when to do it, when to inject. You've got to inject within 15 seconds of when it stops. So the way I set it up is I set up my shot. I have the speculum, everything really close. I put the gun on the eye. I start the process. It tells me when to start, when to stop, when to do the injections. Patients are, patients definitely think it's equivalent to the current therapy. Certain patients think it's even better. What's really nice is it doesn't seem to have a lot as much redness and irritation as they typically feel from an intravitreal injection. Obviously, for patients who are very sensitive to chemicals and betadine, I think it works really well. So I think there's a place for it. It's definitely in the armamentarium that I use. And in those patients that are hard to treat and are you complaining about the way it's working, I think it's something worth doing. It is available from the company, so you can definitely buy the gun and they come in these little tips that are similar to the Tonopen covers that you put on top of them. And again, it's available and you just have to contact the company to use it. But I think it's something else we need to use when we think about our hard to treat patients who don't seem to accept the fact the way that we use either topical or subconjunctival or viscous lidocaine.
How common is lidocaine allergy?
It's pretty rare. And I think, I mean, the lidocaine allergy is what is put on the FDA. I think, you have people that have, it's a relative contraindication. The people who have irritation after injection or feel, lots of hypersensitivity, I think could particularly fall under that lidocaine allergy classification.
So you're saying this is a good approach for patients who are experiencing irritation after topical anesthesia.
Topical or subconjunctival, yeah. You've got these people that are hard to treat that say, look, the process that I feel that after you did the shot, whether it's the combination of betadine and the lidocaine, or just that it really irritates me, or, the eyes get really, really red. Some of those people you want to try on it. Will it work in everybody? That I can't promise you. But again, for people who are willing to give it a try, I think a good percentage of people will prefer it over the conventional therapy. But again, this is a good percentage of people in that population that typically complain of having the injections due to the anesthesia.
So you've got 15 seconds after you apply it to do the injection.
Yep.
Uh, and you put a drop of betadine in to start things off, but
Right.
no topical at all.
No, I put a topical, I do Paracaine, then I put in a drop of betadine, then I do the freezing. Okay. I actually put a little bit of betadine right before I do it with a Q-tip as well. And then I can go right through it. But a lot of people will just basically put the betadine, do the freezing, and go right from there.
So so using the proparacaine is optional.
I would use Proparacaine. It's really the Proparacaine is to basically give anesthesia for the betadine more
Hmm.
than the injection, right? You put betadine in the eye, it's very toxic. So I put a drop of Proparacaine, then I put a drop of betadine in, right? And then I do the freezing, and then I'll put a little Q-tip betadine, but you don't have to, right over that area, and I'll shoot right in. I use the Q-tip just to basically a little for contraction more than anything else. So it's a betadine soaked lidocaine, betadine soaked cotton tip applicator.
Other than cooling anesthesia, can you discuss your intravitreal injection technique?
So that's another interesting concept. So again, I've spent a lot of time looking at intravitreal injections, and one of the things I learned, they did a study a number of years ago looking at the nerve fibers, and what we realized is that, typically I survey people when I give in talks all over the country about where people inject, and a lot of people inject either supratemporal or infratemporal. The interesting thing is when they looked at where the nerve fibers were the lowest, it actually was superior nasal. So posterior nasal potentially has the least amount of nerve fibers. What I'll do is, depending if my patients are pseudophakic, I actually inject them superior nasal. And I have a technique that essentially I put the needle on the eye and I try to get as perpendicular as possible. And I do use gel on a lot of people. You don't need to put pressure in it. You basically has to do with the fact that pressure is force per unit area. So if you think of a high heel versus a flat toe, when you go from the flat toe, if you weigh a certain amount and you go to a high heel, the amount of pressure in a given area actually is much higher when you're on the high heel. That essentially the same thing with the bevel of the needle. If you put it essentially perpendicular, what will happen is as you start rotating it up, there'll be a point that it goes through. I only do it in pseudophakic patients because I'm always worried about potentially causing cataracts when I go superior nasal. But this technique is very efficient. I had a poster on it on ASRS, which shows value to it. But again, it's just another option for people to try to decrease pain. I will tell you that it takes a little more time from the doctor. So when I'm running behind, I'll use it. But if you have lots of text, you're more likely to use a Pledget or subconjunctival anesthesia, depending on your point of view. But what I have learned is that when people give injections, it's all over the map. I mean, some people use speculum, some don't. So it really is an interesting process overall that's constantly evolving, and there's not one right way to do it.
And what do you do for antisepsis?
So here, antisepsis for me, I typically we use betadine, but for patients that are betadine allergic, I mean, you can either obviously use chlorhexidine or hypochlorous acid. I've done some work with hypochlorous acid. I believe it works relatively well. I will tell you, if you use hypochlorous acid, you do not wash it out. You basically irrigate the eye, you do not wash it out. It turns out that hypochlorous acid comes as like a spray, so I actually take a syringe and draw it up and irrigate the eye with it. The studies actually, the funniest thing, the highest risk of bacteria contamination is when you rinse out the eye, believe it or not. So we all want to rinse out the eye, but we probably shouldn't. The problem is the reason we rinse out the eye is with betadine, you don't want the betadine to stick around. But with other, choices like chlorhexidine and more specifically hypochlorous acid, you really want to leave it on so you don't essentially get rid of the bactericidal effects because they last a lot longer than the time of the injection.
Is the company looking to expand the indications for the use of this device in all intravitreal injections?
Absolutely. They want to get phase 4 data, and with the phase 4 data, they're probably going to go back to the FDA to see if they can broaden their label. But because it's a device, as you know, devices have different regulatory pathways. We think about Europe, devices get pretty much approved, immediately. And because it's safe, it typically has a more narrow use. But I think as they get more data together, I think they're going to try to use it without or remove the lidocaine allergy from their label.
So physically, how is the cooling achieved? It's plugged into the wall?
No, it's a battery. So it's a battery pack. It's totally charged. It's a self-contained unit. It literally is a gun. It's a gun that you push. It's funny. So there's a picture of me giving at CTS with me and the James Bond look, like holding this gun up. It literally, you press it. It tells you got to prime it. You click it once. It tells you when it's primed, and then it tells you when it's ready to actually apply on the eye. You click it again. You apply to the eye, and then it basically tells you when to stop. And then you inject. It's totally self-contained. It literally has an instruction thing on it with little tones to let you know when to do it as you go through it. Their salespeople are really good about this. I mean, if it's something you're interested, I would call up the OcuCool people. It's called Recens Medical, RECENS Medical, and talk to them. They'll be happy to demonstrate it. And again, I think there's a place for it in your armamentarium. But again, this is for the high need, hard to treat people. It's not for regular rank and file.
Well, thank you, Michael, for your interesting discussion of cooling anesthesia. I think this is going to expand going forward.
Carmen, I'm always honored to be brought on your program. I think it's great. And I'm excited, the more things we can do to make our patients' lives more comfortable and tolerate intravitreal injections, the higher compliance we get, the better vision we'll keep.
Thank you.
Thanks again for having me.